Welcome. In this session, we'll be discussing about retinopathy of prematurity and briefly about certain other entities which are usually detected in infancy and early childhood and clinically resemble retinopathy of prematurity. Retinopathy of prematurity or ROP is a proliferative retinopathy similar to proliferative diabetic retinopathy and proliferative sickle retinopathy, which occurs in premature infants in whom development of retinal vasculature is yet to complete. And we must note that although prematurity is defined as any delivery before 37 weeks post-conceptional age, ROP usually develops in infants being born before 30 weeks post-conceptional age. Post-conceptional age or post-menstrual age is the time elapsed after the last menstrual period. ROP has the potential to cause bilateral irreversible blindness and is one of the leading cause of childhood blindness in developed world. Globally, it is estimated that 50,000 children below 15 years of age are blind from ROP. The principal cause of retinopathy of prematurity is oxygen, usually as supplemental oxygen therapy immediately after birth, and it has been observed that with elevated blood oxygen levels or hyperoxia, there is vasoconstriction of retinal blood vessels, chiefly the immature retinal blood vessels, and with sustained hyperoxia, there is permanent occlusion of these immature retinal blood vessels. Following termination of supplemental oxygen therapy and normalization of blood oxygen levels, proliferation of endothelial cells occurred from intact blood vessels adjacent to the occluded blood vessels. The temporal retinal blood vessels being the last to mature, the temporal retina remains at risk of developing ROP the longest. On the other hand, although reduction of supplemental oxygen therapy dramatically reduces the incidence of ROP, the reduction of supplemental oxygen therapy results in increased incidence in systemic morbidity and mortality such as respiratory distress syndrome and neurologic disorders. So monitoring oxygen levels and titrating oxygen supplementation is recommended, and this is important to remember, but no consensus about optimal oxygen saturation levels in the blood have yet been reached. The normal development of retinal blood vessels is as follows. Retinal blood vessels develop from embryonic hyaloid vessels in a precursor mesenchymal tissue which advances along the retina from the optic nerve to the periphery ahead of the normal vessels. Capillary networks developing in this mesenchymal tissue mature into arteries and veins and link up with the blood vessels which have already developed and are located just behind this mesenchymal tissue. Retinal blood vessels start to develop at the optic nerve from the embryonic hyaloid vessels at 16 weeks post-conceptional age, grows peripherally, reaches the nasal ora serrata by 36 weeks and the temporal ora serrata by 40 weeks post-conceptional age. And it has been observed that among premature infants with birth weight between 1000 grams and 1250 grams and without clinical ROP, the proportion having blood vessels in the most peripheral retina is 0% at 30 weeks post-conceptional age, 50% at 36 weeks, 90% at 42 weeks, and 100% at 48 weeks post-conceptional age. Also, 80 to 90% of these infants develop normal mature retinal blood vessels on schedule without developing retinopathy of prematurity. Vascular endothelial growth factor is an important factor guiding the development of blood vessels. Under normal conditions, VEGF is a survival factor for developing endothelial cells. Therapeutic hyperoxia from supplemental oxygen therapy initially downregulates VEGF, causing death of developing endothelial cells, resulting in ischemia and hypoxia of differentiating avascular peripheral retina. So systemic hyperoxia leads to hypoxia of differentiating avascular peripheral retina, and this is very important to understand in the pathogenesis of ROP. This hypoxic differentiating avascular peripheral retina secretes VEGF and other growth factors which lead to neovascularization. According to Flynn, the pathogenesis of retinopathy of prematurity is as follows. Endothelial cells of the primitive capillary network which has just formed from the mesenchyme are prone to injury from hyperoxia. The surviving mature arteries and veins form a mesenchymal arteriovenous shunt bypassing the injured capillaries as seen here in a fluorescent angiogram from a premature infant. The shunt lies at the demarcation between the peripheral avascular and the central vascular retina and is the pathognomonic feature of acute ROP. Acute ROP is the active stage of the disease, which we will be discussing in detail. The mesenchymal arteriovenous shunt subsequently thickens to form a ridge, which we will discuss, and the primitive endothelial cells in the shunt may either mature into normal capillaries when they proliferate inside the avascular anterior retina, which signifies involution of retinopathy or prematurity, which occurs in the majority of premature infants with this stage or stage 2 of ROP, which we will be discussing further, or proliferate through the internal limiting membrane and grow over the retina, signifying progression or deterioration of ROP. According to Fuss, there are two cellular components in the mesenchyma of the developing retina: the vanguard or the anterior cells, which appear spindle-shaped, which were initially thought to be astrocytic precursors but now considered to be endothelial precursors, and which nourish the immature retina anteriorly, and the rear guard or the posterior cells, which are considered to be primitive endothelial cells, which develop into mature capillaries for the anterior retina. In retinopathy or prematurity, the demarcation line is said to arise from hyperplasia of vanguard cells, and the ridge is said to arise from hyperplasia of both the vanguard and the rear guard cells, but neovascularization arises only from the rear guard cells, and condensation of vitreous adjacent to this junction of the vascular and the avascular retina has been detected in eyes with ROP and implicated to induce vitreoretinal traction. The established risk factors for development of ROP include, of course, prematurity, low birth weight, prolonged supplemental oxygen therapy, and complicated hospital stay with development of sepsis, intraventricular hemorrhage, and necrotizing enterocolitis, requirement of blood transfusion, and a slow weight gain, and these are important to remember. Two phases of ROP are well known: an active phase and a regressed phase. Active ROP usually occurs from 34 weeks to 55 weeks post-conceptional age, and regressed ROP describes the sequelae following involution of active ROP, with this sequelae persisting long-term or even lifetime. So it is important to note that active ROP develops and progresses within a very short period following birth in premature infants. We will first be describing the clinical features and management of acute ROP and then describe regressed ROP. The clinical features of acute ROP are best described according to the description of International Classification of ROP or ICROP, which had several editions from 1984 to as late as 2021. The ICROP system classifies the disease in an individual patient based on location of the disease within the retina, the stage of the disease, the presence of plus or pre-plus disease, and presence of aggressive ROP. As we will discuss these individual parameters, we will also mention the edition of ICROP, which initially described that parameter, so that we have an idea of the chronology of understanding of this disease process. The more posterior the zone of the disease, the wider the extent, the higher the stage, and the presence of plus disease or aggressive ROP, the more severe the disease is considered to be. And in an individual eye, the stage of the disease is described as the most severe ROP stage present in any portion of the retina of that eye, and the zone of the disease is described as the most posterior zone where the most severe ROP stage is present. The zones of the disease were described in the initial edition of ICROP, and in an individual patient, the zone of the disease is categorized as the most posterior region where retinal vascularization is visible or ROP lesion is detected. We will be describing the ROP lesion when we discuss the stages of the disease. So zone 1 is a zone delimited anteriorly by a circle centered on the optic disc, with the radius of the circle being twice the distance from the center of the optic nerve head to the center of the macula. Zone 2 is an annulus between zone 1 and a circle centered on the optic nerve head and passing tangential to the nasal ora serrata. Temporally, it corresponds to the equatorial region of the temporal retina. And zone 3 is the temporal crescent anterior to zone 2, and as we have mentioned, it is the last zone to vascularize during development. Identifying the fovea can be difficult in premature infants, and in these patients, either the center of the macula between the temporal arcades is considered as the fovea, or when indirect ophthalmoscopy is done with a 28 diopter lens and the nasal edge of the optic nerve head is placed at the nasal edge of the field of view. The temporal edge of the field of view corresponds to the temporal anterior limit of zone 1. The 2021 edition of ICROP introduced two more terms, posterior zone 2 and notch. Posterior zone 2 is actually a portion of the original zone 2 extending 2 disc diameters anteriorly from the junction between zone 1 and zone 2. And notch is an incursion of ROP lesion into a more posterior zone than the remainder of the ROP lesion for 1 to 2 clock hours in the horizontal meridian, as seen here in this clinical photograph. So when this incursion is from zone 2 to zone 1, the zone description of ROP is zone 1 secondary to notch. The extent of the disease was described in the initial edition of ICROP, and for this description, the fundus is divided into 12 30-degree sectors labeled as clock hours, as shown here in this diagram. And the description of the disease in an individual eye includes the number of sectors involved in the disease process. Following the publication of the CRYO-ROP study, the extent of the disease was considered in deciding therapy of ROP, but the current indications for treatment of ROP do not consider the clock hour extent of the disease. 5 clinical stages of ROP have been described, and immature retina is a normal finding in a premature infant when no sign of any of these 5 clinical stages of ROP can be detected. And in an immature retina, the retinal blood vessels are yet to reach the ora serrata, so a portion of the anterior retina is still avascular, as seen here in this clinical photograph. Stage 1 ROP is characterized by a flat demarcation line as represented by this yellow zone in this diagram between the anterior avascular retina and the posterior vascular retina. Demarcation line is the first ophthalmoscopic sign of ROP but is not considered as a pathognomonic sign of ROP. Demarcation line, as seen here in this clinical photograph, appears flat lying within the plane of the retina and is usually white in color. This flat appearance of demarcation line is very important to remember. As we have mentioned, demarcation line occurs due to hyperplasia of primitive mesenchymal cells, particularly the spindle cells, and demarcation line is usually relatively evanescent, either progressing to stage 2 ROP or involuting to normal retinal vascularization. Stage 2 ROP is characterized by a ridge which originates from the demarcation line and has height, width and volume as shown here in this diagram. As we have mentioned, the ridge consists of proliferating endothelial cells as well as spindle cells, and the ridge appears to be elevated from the plane of the retina as seen here in this color photograph and appears white to pink in color. And this is another clinical photograph showing a ridge, and small vessels may be seen to terminate in small tufts of vessels posterior to the ridge, which are called popcorn vessels. Stage 3 ROP is characterized by extraretinal fibrovascular proliferation arising from the posterior aspect of the ridge and infiltrating the vitreous cavity as shown here in this diagram and as can be seen here in this clinical photograph. And because of this extraretinal fibrovascular proliferation, the ridge becomes ragged in appearance. Extraretinal proliferation is composed of proliferating endothelial cells and do not contain mesenchymal spindle cells. This clinical photograph is also that of stage 3, showing a ridge having a ragged appearance due to extraretinal proliferation. And this is a magnified view of a ridge with extraretinal proliferation. The 1987 edition of ICROP described the stages 4 and 5 of ROP, which are characterized by retinal detachment. Stage 4A ROP describes a partial retinal detachment with an attached fovea, characterized by a concave-shaped tractional retinal detachment not involving the fovea. This fractional retinal detachment originates at the ridge and may occur in any zone in an individual eye with ROP, and the tractional retinal detachment occurs in a circumscribed purse string pattern parallel to the limbus, drawing the retina centrally and anteriorly. This yellow line represents the adherent posterior vitreous cortex. and the partial retinal detachment of stage 4A can involve the peripheral retina in one sector or circumferentially all around but spares the fovea. And because of this sparing of fovea anatomically and visually, the prognosis of stage 4A ROP, if it doesn't progress further, is relatively good. Stage 4B ROP is characterized by fovea involving partial retinal detachment, which usually arises from progression of a pre-existing stage 4A retinal detachment in the peripheral retina as shown here in this diagram, but may alternatively arise as a retinal fold from the optic disc region. And once the fovea is involved in a retinal detachment, prognosis for visual acuity becomes very guarded. So this photograph shows a partial retinal detachment involving the foveal region. Macular ectopia or displacement of the macula, usually temporally, and straightening of retinal vessels is often found in stage 4 ROP. Exudative retinal detachment can occur and usually occurs following treatment of ROP. Volcanoretinal detachment can also be found in ROP, in which the fovea is detached but the treated peripheral retina is attached, and usually occurs following treatment of aggressive ROP. And treatment here refers to ablation of the peripheral avascular retina, usually with laser but sometimes with cryo, which we will be discussing. Stage 5 ROP refers to total retinal detachment as seen here in this clinical photograph, and the retinal detachment in ROP is typically funnel shaped, and the term retrolental fibroplasia, originally used to describe ROP, corresponds to stage 5 ROP, in which the detached retina becomes visible immediately posterior to the crystalline lens. Total retinal detachment in stage 5 ROP may be of various configurations, which may require USG for characterization. The most common configuration is a funnel, which is open anteriorly as well as posteriorly, and in this configuration only the optic disc remains visible. Another configuration is a funnel which is narrow anteriorly as well as posteriorly, and in this situation the retina appears to be located just posterior to the crystalline lens, as we have discussed. The third configuration is a funnel which is open anteriorly but narrow posteriorly, and the least common configuration is a funnel which is narrow anteriorly but open posteriorly, and here also the retina appears to be located immediately posterior to the crystalline lens. The 2021 edition of ICROP further subcategorized stage 5 ROP to permit more detailed clinical description. Stage 5A refers to stage 5 ROP in which optic disc remains visible ophthalmoscopically. Stage 5B refers to stage 5 ROP in which the optic disc is not visible ophthalmoscopically, either because of a closed funnel retinal detachment or due to retrolental fibrous tissue. And stage 5C refers to stage 5B ROP in which optic disc is not visible with anterior segment changes such as marked anterior chamber shallowing, anterior displacement of the crystalline lens, posterior synechia, and central corneal clouding. The 2021 edition of ICROP also stated that in premature infants, if ROP lesions are not detected during examination, the term incomplete vascularization should be used, mentioning the most posterior zone of vascularization, or rather the most posterior zone of absence of vascularization, instead of the terms no ROP or immature retina. Other clinical features associated with stage 4 or stage 5 ROP, particularly with stage 5 ROP, include fibrovascular tissue in retrolental space, as we have discussed, which appears translucent when the disease is in the active stage but become whitish with few blood vessels following regression of ROP, and this is called retrolental fibroplasia. A peripheral gutter may be detected in eyes with stage 5 ROP, which appears as a peripheral red reflex in association with an anterior narrow funnel RD, and this peripheral red reflex arises from an attached or shallowly detached peripheral avascular retina. Shallowing of anterior chamber in stage 5 ROP may progress to acute angle closure glaucoma and further to corneal decompensation. Iris abnormalities with stage 5 ROP include rubeosis with ectropion pupillae, pupillary rigidity, posterior synechia, and seclusion pupil with iris bombay. Plus disease was described in the initial edition of ICROP and was defined as dilatation of veins and tortuosity of arteries and veins in the posterior pole, that is zone 1, more severe than that defined by a standard photograph. This color photograph shows the fundus of an eye with ROP, showing dilatation of veins and tortuosity of the arteries, indicating the presence of plus disease. Plus disease denotes a severe form of ROP but should be differentiated from aggressive ROP. Plus disease may be associated with iris vascular engorgement, pupillary rigidity and vitreous haze, and these signs are currently considered as signs of advanced disease but are not necessary for definition of plus disease. Plus disease is said to occur secondary to arteriovenous shunting of blood at the ridge. The CRYO-ROP study required dilatation and tortuosity of blood vessels to be present in all four quadrants of the fundus for labeling the disease as plus, but ETROP study required presence of this feature in at least two quadrants only to label the disease as plus. The 2005 edition of ICROP introduced the term pre-plus disease to describe the presence of arteriolar tortuosity and venous dilatation at the posterior pole, which is less severe than the standard photograph, and it has been found that the majority of eyes with ROP with pre-plus disease go on to require ablative therapy. So diagnosis of pre-plus disease is important in that respect. Significant subjective variability among examiners exists in diagnosis of either plus or pre-plus disease. The term aggressive ROP was introduced in the 2005 edition of ICROP, and this entity was previously known as rush disease or aggressive posterior ROP. It was initially described in zone 1 and posterior zone 2 in extremely premature infants, but now it has been found that it can also occur in more anterior retina and in larger preterm infants, particularly in resource-limited countries. So the word posterior has been discarded from the term aggressive ROP. Aggressive ROP is a rapidly progressing entity characterized by severe plus disease out of proportion to other ROP findings, areas of flat extraretinal neovascularization in the peripheral retina as seen here in this clinical photograph, and also in this clinical photograph posterior to the border between the avascular and vascular retina. Flat extraretinal neovascularization is characteristic of aggressive ROP and is important to remember, and it corresponds to the stage 3 of Tasic ROP, which is typically elevated from the retina. In aggressive ROP, ridge or demarcation line may be either difficult to discern or may be absent. Aggressive ROP does not show stage-wise progression and may rapidly progress to stage 5 total retinal detachment. ROP typically begins to involute or regress after 38 weeks post-conceptional age, and this is also the post-conceptional age which is considered to be full term, and this is important to remember to understand the time course of the disease process of ROP. And regression of ROP may be characterized by either downgrading of staging or growth of normal retinal vessels into a more peripheral zone of the retina. And as we have already mentioned, the predominant majority of ROP patients screened spontaneously regress, and only 10% of ROP patients screened progress to a stage requiring treatment. The 2021 edition of ICROP described the signs of regression which may occur either spontaneously or following treatment, and they include reduction of plus disease, decrease in media haze, progression of normal vascularization towards peripheral retina across the ridge anteriorly towards the ora serrata, thinning and whitening of fibrovascular tissue, better pupillary dilatation, and reduction of intraretinal hemorrhage which may have occurred from the neovascular process. The 2021 edition of ICROP defined reactivation of ROP following introduction of anti-VEGF therapy for ROP, and here it is important to note that introduction of anti-VEGF therapy for ROP altered the time course of the disease process. Reactivation of ROP may occur following incomplete or complete regression after the initial disease, or either spontaneously or following initial treatment. Reactivation of ROP typically occurs after anti-VEGF therapy for ROP, less commonly after spontaneous regression, and almost never after laser or cryoablation for ROP, and this is important to remember. And reactivation of ROP typically occurs between 37 and 60 weeks post-conceptional age. And because of this, the follow-up schedule of ROP patients treated with anti-VEGF is different from the follow-up schedule of ROP patients treated with either laser or cryoablation. Signs of reactivation of ROP include recurrence of pre-plus or plus disease, reappearance of ROP lesion ranging from demarcation line to stage 3, typically at the site of the original ridge or the anterior margin of the normal retinal vessels, which have advanced anteriorly following initial regression, and the extraretinal neovascularization of reactivated ROP are more delicate and so more difficult to visualize as compared to the initial disease. Worsening vitreous haze and pupillary rigidity are other signs of reactivation of ROP, and reactivated ROP may not progress through the conventional stages of the initial disease prior to treatment. It is important to note that the terms threshold and pre-threshold ROP were not defined by ICROP but were defined by CRYO-ROP and ETROP studies respectively. Threshold ROP as defined by CRYO-ROP study in 1988 is the presence of stage 3 disease, that is a ridge with extraretinal neovascularization with plus disease, for 5 contiguous clock hours or 8 non-contiguous clock hours in zone 1 or zone 2 of the retina. The severity of the disease was called threshold ROP because in the natural history cohort of the CRYO-ROP study, ROP at this level had equal chances of either spontaneous regression or progression to more severe disease. This definition of threshold ROP is very important to remember. In the CRYO-ROP study, a significant proportion of patients who were treated on or after reaching threshold developed unfavorable outcome long term, and so the ETROP study, which evaluated the efficacy of laser photocoagulation in ROP, included another spectrum of ROP eyes which were yet to reach threshold and which the ETROP study defined as high-risk pre-threshold ROP. High-risk pre-threshold ROP as defined by ETROP is further subclassified into type 1 ROP and type 2 ROP. Type 1 ROP is defined as the presence of any one of zone 1 any stage ROP, even a demarcation line in the presence of plus disease, or zone 1 stage 3 ROP even in the absence of plus disease, or zone 2 stage 2 or 3 ROP in the presence of plus disease. The ETROP study concluded that type 1 ROP patients need immediate ablative treatment, and this is still the current indication for treating ROP. And patients with type 2 ROP as defined by ETROP require close follow-up once or twice in a week. In neonates, proliferative retinopathy is almost always due to ROP, but in older infants and children, differential diagnosis of peripheral retinal ischemia and tractional retinal detachment include familial exudative vitreoretinopathy, Incontinentia pigmenti, Norris disease, and ocular toxocariasis. Unlike ROP, none of these clinical entities have a history of prematurity. And differential diagnosis of white reflex in the eye, which may correspond to the presence of retrolental fibroplasia of ROP, include retinoblastoma, Coats disease, and persistent fetal vasculature. Persistent fetal vasculature and Coats disease are typically unilateral, and Coats disease shows subretinal lipid exudation, which typically does not occur in patients with ROP. And we will be discussing familial exudative vitreoretinopathy, Incontinentia pigmenti, and persistent fetal vasculature in this session. Screening for ROP is based on the fact that ROP occurs on a schedule according to infant's post-conceptional age and not his or her chronological age. In the CRYO-ROP study, it was found that among infants with birth weight 1 to 51 grams or less, stage 1 ROP typically develops at 34.3 weeks post-conceptional age, and stage 2, stage 3 and stage 4 or 5 ROP typically develop in sequential later post-conceptional age. The screening protocol recommended by American Academies of Ophthalmology and Pediatrics required screening for ROP for all infants being born at 30 weeks or less post-conceptional age and or having birth weight less than 1500 grams, and this is very important to remember. But some other organizations also recommend screening for ROP in infants born between 30 and 32 weeks also, and for infants having birth weight between 1500 and 2000 grams and or being born at a post-conceptional age of more than 30 weeks, ROP screening is recommended if they have an unstable clinical course in the neonatal period. The online BEAT-ROP calculator can identify infants at high risk of developing ROP based on birth weight and serial weekly weight gain, and this prediction can be made as early as 6 weeks prior to onset of ROP. Patients with poor weight gain are at higher risk of developing severe ROP. This method has been found to have a low sensitivity but high specificity and should be thus used as an adjunct to standard screening criteria. The BEAT-ROP method initially included both weight and serum levels of insulin-like growth factor 1, but presently the BEAT-ROP calculator considers only the birth weight and weekly weight gain. The time for first eye examination in a premature infant is at 31 weeks for those being born at 27 weeks post-conceptional age or earlier, or 4 weeks after birth for those being born after 27 weeks. And this recommendation can also be stated as the time for first eye examination is at 31 weeks or 4 weeks after birth, whichever is later. This is also very important to remember. Screening requires indirect ophthalmoscopic examination, which can be stressful for an infant, and so screening examination should be done with the approval of a neonatologist and in the presence of a nursery staff who can monitor vitals and address apnea, bradycardia and other adverse effects if they occur during screening. Prior to pupil dilatation, the iris needs to be checked for vascular engorgement and rubeosis, which are indicators of severe disease. The pupils need to be dilated with recommended concentrations of tropicamide phenylephrine or cyclopentolate, and the excess amount of drug should be immediately wiped off from the eyes to prevent the occurrence of systemic complications such as hypertension or ileus. Poor dilatation of the pupil following application of dilated drops is also an indicator of aggressive disease. A speculum is required to open the eyelids and the infant's hands need to be restrained. Dilated anterior segment examination of a premature infant may show persistent tunica vasculosa lentis as shown here in this clinical photograph, and tunica vasculosa lentis normally regresses shortly before birth and so is not found in eyes of full-term neonates. During indirect ophthalmoscopy, the zone, extent and stage of the disease needs to be determined and the optic nerve needs to be checked for presence of plus disease. Scleral depression with or without rotation of the eye is required to check the periphery to determine the extent of normal retinal vascularization, and proper sterility or disinfection measures should be taken prior to examining each infant. Telemedicine is increasingly playing a role in screening of ROP, and the photo-ROP study defined clinically significant ROP or referral threshold by these criteria based on fundus photography to identify infants who required in-person examination by an ophthalmologist, and the ETROP study analyzed the efficiency of training of non-physicians to grade ROP based on ultra-wide field fundus photography. The current indication for management of ROP is that eyes developing or having type 1 high-risk pre-threshold or worse ROP should undergo treatment within 72 hours of diagnosis. In ROP eyes requiring treatment but without retinal detachment, treatment options include ablation of peripheral avascular retina either with laser or cryo, but laser photocoagulation is currently the mainstay of treatment given its proven efficacy, safety and durability. But cryo may be required in eyes with hazy media in which laser photocoagulation is not possible. Anti-VEGF injections is also a treatment option for ROP eyes requiring treatment but without retinal detachment, and in eyes with retinal detachment, vitreoretinal surgery is required. The multi-center trial of cryotherapy for ROP, or the CRYO-ROP study, was a landmark clinical trial in the management of ROP, and it published its 10-year results in 2001. The treatment cohort of CRYO-ROP study consisted of 291 preterm infants with birth weight less than 1 to 5 grams having threshold ROP in one or both eyes. The eyes of infants with bilateral threshold ROP, which comprised the majority of infants in the treatment cohort, were randomized to treatment for one eye and observation for the other eye. And for infants with unilateral threshold ROP, comprising a minority of patients within the treatment cohort, were randomized to either treatment for the eye with threshold disease or observation. We may note here that the CRYO-ROP study did not have a post-conceptional age at birth requirement for inclusion in the study. This photograph was taken when cryo was being applied, and this photograph was taken several weeks later. After 10 years of follow-up, unfavorable functional outcome defined as visual acuity less than 20/200 and unfavorable structural outcome defined as macular retinal fold, macular detachment and retrolental mass obscuring view of the posterior pole were significantly more in the untreated group as compared to the treated group, and the incidence of total retinal detachment continued to increase in untreated eyes during the follow-up period but remained stable in the treatment group. The CRYO-ROP study also had a natural history cohort of premature infants with similar birth weight criteria and with ROP severity ranging from no ROP to stage 3 plus ROP, that is without any retinal detachment. And at 5.5 years, unfavorable structural outcome occurred in 44.2% of infants who developed zone 2 stage 3 plus disease of more than 6 clock hours extent during acute stage of ROP, and in 62.5% of infants who developed zone 1 disease during acute stage of ROP. And from these observations, the criteria for threshold ROP was developed. Unfavorable visual outcome defined as visual acuity of 20/200 or less occurred in 68.8% of infants in the natural history cohort who developed zone 1 disease during acute phase of ROP, but was much less common in infants having zone 2 or zone 3 disease during acute phase of ROP. Laser photocoagulation is currently the preferred method of ablating the peripheral avascular retina. As compared to cryotherapy, laser photocoagulation is easier to administer with a laser indirect ophthalmoscope, causes less post-operative swelling and inflammation, and produce equivalent or better outcomes, particularly in patients with posterior ROP. For laser photocoagulation, mydriasis and speculum is required, and near confluent laser burns, defined as burns spaced half a burn width apart, is applied to the peripheral avascular retina as shown here in this clinical photograph. A diode laser is preferred and the power is titrated to gray-yellow burns. Laser photocoagulation is started from the anterior border of the vascular retina but not including the ridge and extended up to the ora serrata, either by rotating the eye or using a scleral depressor. Sparser treatment is recommended along horizontal meridia to spare long ciliary nerves and arteries in order to prevent anterior segment ischemia and neurotrophic keratopathy. Laser photocoagulation for ROP is preferably done in a single sitting, as hyphema or vitreous hemorrhage after a laser sitting may preclude subsequent treatment. Multiple sittings may be required for poor visibility or patient distress during treatment. Considering systemic management during treatment is very important, and laser photocoagulation is ideally performed either in the NICU or in the operating room. Adequate analgesia or anesthesia in the form of general anesthesia or topical or local anesthesia with conscious sedation should be employed, and the method of analgesia or anesthesia depends on the health status of the infant, posterior extent of ROP, and experience of the neonatologist and ophthalmologist. Continuous monitoring of heart rate, breathing status, oxygen saturation levels by a neonatal nurse, and availability of neonatologist for resuscitation are mandatory. Complications of laser include anterior segment ischemia, high myopia, burns on the cornea, iris or tunica vasculosa lentis, or thermal injury to the crystalline lens causing cataract. Considering that a significant proportion of infants in the treatment cohort of CRYO-ROP study had an unfavorable outcome, the early treatment for retinopathy of prematurity or ETROP study compared the efficacy of early treatment prior to reaching threshold versus conventional treatment after reaching threshold. And ETROP included 401 infants with a birth weight less than 1251 grams who had high-risk pre-threshold ROP unilaterally or bilaterally. We have already defined high-risk pre-threshold ROP earlier in this session. Like the CRYO-ROP study, the ETROP study also did not have a post-conceptional age at birth requirement for inclusion in the study. The majority of patients in the ETROP study had bilateral high-risk pre-threshold ROP, and in these patients, the eyes were randomized with one eye to early treatment group receiving immediate laser photocoagulation and the other eye to conventional treatment group receiving treatment mostly laser photocoagulation only after reaching threshold. And in infants with unilateral high-risk pre-threshold ROP, the infants were randomized to either early treatment group for immediate treatment of the eye with high-risk pre-threshold ROP or to a conventional treatment group in which that eye received treatment, mostly laser photocoagulation, only if it reached threshold. The ETROP study found that unfavorable structural outcome defined as macular retinal fold macular detachment or erythrolental mass occurred in a higher proportion of patients in the conventional treatment group as compared to that in the early treatment group, both at 9 months and 2 years of follow-up. Unfavorable functional or visual acuity outcome was assessed at 9 months of age with Teller acuity cards, and even at this age, a higher proportion of patients in the conventional treatment group was found to have a worse visual acuity outcome as compared to that in the early treatment group. At 6 years, visual acuity was recorded with ETDRS chart, and a visual acuity of less than 20 by 200 was defined as an unfavorable functional outcome. And at this age, among eyes which originally had type 1 high-risk pre-threshold ROP, a significantly higher proportion of eyes which were originally in the conventional treatment group had an unfavorable functional outcome as compared to eyes in the original early treatment group. But among eyes originally with type 2 high-risk pre-threshold ROP, the difference in unfavorable functional outcome was not significant. And following these results, ETROP study recommended laser ablation of peripheral avascular retina in ROP patients reaching type 1 high-risk pre-threshold disease. Presently, anti-VEGF therapy is an option for treating ROP patients, and anti-VEGF injection in an ROP eye allows normal retinal vascularization to progress and proceed towards avascular retina, which does not occur following ablation of the peripheral retina, either with laser or with cryo. But incomplete vascularization is very common following anti-VEGF therapy. As we have discussed earlier, reactivation of ROP can occur several weeks after initial regression following anti-VEGF therapy, and so anti-VEGF therapy is not recommended for infants with ROP who may not adhere strictly to the follow-up schedule. And there is also concern regarding systemic VEGF inhibition, which may interrupt normal angiogenesis, including that in the eye, and also organogenesis. Compared to laser, anti-VEGFs are much easier to administer, allow preservation of peripheral visual fields, and are less likely to induce refractive errors. Anti-VEGF injections are particularly useful in ROP eyes with poor dilatation of the pupil or rubeosis, media haze, posterior disease, aggressive disease, and in infants who are not able to tolerate laser or general anesthesia for laser. But laser therapy remains the mainstay of treatment given its proven efficacy, safety, and durability. Anti-VEGF injections can be performed under topical anesthesia in NICU, and particular care regarding sterility of the procedure should be taken. In contrast to anti-VEGF injections in adults, in infant eyes, only 0.025 ml volume can be injected, 0.5 to 1 mm posterior to the limbus, with the needle directed more posteriorly, almost parallel to the visual axis. And following intravitreal injection, perfusion status of central retinal vessels should be confirmed with indirect ophthalmoscopy. As we have already discussed, Recurrence or reactivation of ROP is common following anti-VEGF injections, and the highest risk of recurrence is between 2 and 4 months following injection. So there is a need for close follow-up with special caution before terminating follow-up of ROP infants treated with anti-VEGF. Completion of normal retinal vascularization up to the ora serrata is the only safe criteria to terminate follow-up, but as we have mentioned, incomplete vascularization is very common. Alternatively, it is recommended that following anti-VEGF injections for ROP, follow-up should be continued at least 16 weeks after injection or attainment of 65 weeks post-conceptional age, and this is important to remember. And following anti-VEGF therapy, laser treatment is required in infants who do not have complete revascularization of the peripheral retina even at this late, that is 65 weeks or more post-conceptional age, and many prefer to perform definitive laser photocoagulation before discharging these patients from NICU. The BEAT-ROP study compared the efficacy of intravitreal bevacizumab, half the adult dose of bevacizumab in half the adult volume, versus conventional laser in infants with bilateral treatment requiring ROP. Infants were randomized between two treatment groups, and both eyes of each infant were treated with the same method, either bevacizumab or conventional laser. A total of 150 infants were included who had birth weight less than 1500 grams and were born at less than 30 weeks post-conceptional age. At 54 weeks post-conceptional age, recurrence of neovascularization in one or both eyes requiring retreatment in the BEAT-ROP study occurred more frequently in conventional laser group as compared to the bevacizumab group among infants with zone 1 ROP, but the difference was not significant between the two treatment groups among infants with posterior zone 2 disease, and the average interval of recurrence of ROP following bevacizumab injection was 16 weeks in the BEAT-ROP study, sooner in eyes with zone 2 disease as compared to zone 1 disease. And this figure in the result from the BEAT-ROP study was not universally accepted because it did not match the result from the ETROP study. The Rainbow study compared the efficacy and safety of two doses of ranibizumab, 0.2 mg and 0.1 mg versus laser in infants with ROP requiring treatment, and a total of 225 infants were randomized into the three treatment groups. In the Rainbow study, at 24 weeks post-treatment, treatment success as defined here was achieved in a higher proportion of patients receiving ranibizumab 0.2 mg as compared to that in the laser group, and the study concluded that ranibizumab 0.2 mg may be superior to laser therapy. The study by PEDIG was a bevacizumab de-escalation study and was performed because of concern regarding systemic VEGF inhibition, and also because it was found that the 0.625 mg dose used in the BEAT-ROP study delivers 10,000 times the amount of anti-VEGF than VEGF present in an infant eye with ROP. A total of 59 infants with type 1 pre-threshold ROP in one or both eyes were included, and one eye of each infant was treated with bevacizumab, and the doses of bevacizumab evaluated ranged from 0.016 mg to 0.002 mg, which were given in batches of 10 to 14 infants. At 4 weeks post-treatment, successful outcome was achieved in a very high proportion of patients in all the groups except the group receiving 0.002 mg bevacizumab. So the PEDIG study concluded that 0.004 mg may be the lowest effective dose of bevacizumab for treatment of ROP. The FIREFLEYE study, note the spelling, compared the efficacy of intravitreal aflibercept versus laser photocoagulation, and a total of 118 premature infants with treatment requiring ROP in at least one eye were randomized to the two treatment groups, aflibercept and laser. And at 24 weeks following treatment, similar success rate was achieved in both the aflibercept and the laser group in the FIREFLEYE study. So the FIREFLEYE study concluded that aflibercept was non-inferior to laser as regards treatment success. The BUTTERFLEYE study, again note the spelling, also compared the efficacy of intravitreal aflibercept versus laser and included 120 premature infants with ROP requiring treatment who were randomized to the two treatment groups. At 52 weeks postnatal age, the BUTTERFLEYE study found similar success rates in both the aflibercept and laser groups. And the BUTTERFLEYE study also concluded that intravitreal aflibercept was non-inferior to laser. Surgery is required to attempt salvaging eyes with stage 4 and stage 5 ROP, and lens pairing vitrectomy is recommended for stage 4 ROP, while lensectomy vitrectomy is recommended for stage 5 ROP. Since scleral buckle may interfere with normal growth of the eye and induce significant anisometropia, scleral buckle is not usually used in surgery for retinal detachment from ROP. And it has been found that surgery performed at stage 4A has a better outcome than that performed at stage 4B or stage 5. And after 5 years of surgery for retinal detachment from ROP, the retina remains fully attached in only 25% of cases. And if iatrogenic retinal break occurs or a drainage retinotomy is made intraoperatively, prognosis is uniformly poor. So results of surgery for retinal detachment from ROP is not very promising. The tractional vectors which need to be neutralized during surgery are from ridge towards ridge, from ridge towards eye wall, from ridge towards ciliary body, from ridge towards posterior lens surface, from optic disc towards ridge, and from the central stalk towards center of the drumhead. The drumhead is the diaphragm-like fibrous tissue lying at the level of the ridge. Follow-up schedule for ROP eyes should be considered separately for untreated eyes with disease severity less than type 1 pre-threshold ROP, for treated eyes, and separately for eyes treated with laser and eyes treated with anti-VEGF injections, for eyes with regressed ROP, which we will be discussing subsequently. And also, termination of follow-up following acute ROP must also be taken into account. The follow-up interval should be less than 1 week for type 2 high-risk pre-threshold disease, which is stage 1 or stage 2 disease without plus in zone 1 and stage 3 disease without plus in zone 2. The interval should be between 1 and 2 weeks for regressing ROP in zone 1 and immature retina in zone 1, and also for stage 2 and no plus disease in zone 2. 2 weekly follow-up intervals is adequate for eyes with stage 1 and no plus disease in zone 2, and for eyes with regressing ROP in zone 2. And for eyes with less severe ROP, the follow-up can be at 2 to 3 week intervals. Following treatment with laser or cryo, the infant needs to be examined 1 week later when some reduction of disease severity, particularly plus disease, is evident. Then the infant should be followed up weekly, and if regression is found to be inadequate, supplementary treatment should be administered to skip areas. By 1 month following laser or cryo, obvious improvement and even complete regression of ROP occurs. And as we have mentioned earlier, reactivation of ROP is very infrequent following initial regression after treatment with laser or cryo. Following treatment with anti-VEGF, a very close follow-up is recommended till criteria for termination of follow-up is achieved. And this is because, as we have mentioned, reactivation of ROP is very common following treatment with anti-VEGF. Follow-up can be terminated under any one of the following circumstances in either untreated eyes or eyes treated with laser or cryo, and these criteria are attaining 45 weeks post-conceptional age without developing type 1 high-risk pre-threshold disease or worse, progression of normal retinal vascularization to zone 3 without prior zone 1 or zone 2 ROP, and signs of regression of ROP, which we have discussed earlier. And criteria for termination of follow-up in ROP eyes treated with anti-VEGF are completion of normal retinal vascularization within 1 disc diameter of ora serrata 16 weeks following injection, or attainment of 65 weeks post-conceptional age without reactivation of ROP. And follow-up for regressed ROP should preferably involve a pediatric ophthalmologist and start at 6 months to 1 year of age and continue periodically long term. Regressed ROP or cicatricial ROP is the second phase of ROP following involution of acute or active ROP. It was first described in the 1987 edition of ICROP and includes several ocular morbidities which are known to occur in ROP patients later in life with or without development of retinal detachment during the phase of active or acute ROP. And as we have already mentioned, to screen for ocular morbidities of regressed ROP patients require regular examinations long term. Fractional regmatogenous combined or exudative retinal detachment can occur any time in life in regressed ROP patients, but commonly occurs in the first several years following birth. So in patients of any age with a history of prematurity and high myopia since early childhood, high myopia being a typical feature of regressed ROP, peripheral retinal examination needs to be done carefully to detect clinically undiagnosed regressed ROP. This is because regressed ROP patients are also found to have a higher incidence of retinal detachment following cataract surgery later in life and also a higher failure rate following repair of retinal detachment. In addition to retinal detachment, there are numerous other retinal changes of regressed ROP, and we'll be mentioning only a few. Peripheral vascular changes may include failure to vascularize peripheral retina and circumferential interconnection between arcades. Peripheral retinal changes may include lattice-like changes, peripheral folds, retinal breaks, and retinoschisis. Vascular changes in the posterior fundus include straightening of temporal blood vessels as seen here in this clinical photograph, and retinal changes in the posterior fundus include macular folds which may extend to the periphery as also seen here in this clinical photograph, and macular heterotopia, that is displacement of the macula from its normal position. SD-OCT and OCT angiography have demonstrated cystoid macular edema in a large proportion of ROP infants during acute stage of the disease. Small or absent foveal avascular zone as seen here in this OCT angiogram and preservation of inner retinal layers in the fovea can be found in ROP infants and also later in their adulthood. This diagram represents OCT of an ROP eye showing retention of the inner retinal layers in the region of the fovea as compared to centrifugal displacement of the inner retinal layers from the fovea of a normal eye. Strabismus and amblyopia are quite common in eyes with regressed ROP, and refraction, vision testing, and extraocular muscle function assessments are required at regular intervals till 18 months of age and then as clinically needed. Myopia and anisometropia are also common in eyes with regressed ROP, and anterior segment examination of eyes with regressed ROP can show corneal changes including irregularity of corneal curvature, acute hydrops and band keratopathy, cataract, and glaucoma, typically angle closure glaucoma, and so parents should be educated to report when they notice red eye and or corneal haze. Now we'll briefly discuss about the other entities which clinically resemble ROP, and we'll discuss Coats disease in the next session. Persistent fetal vasculature or PFV was previously known as persistent hyperplastic primary vitreous, and it occurs due to incomplete regression of the vascular primary vitreous. PFV is mostly sporadic but rarely may occur with a mutation in the ATOH7 gene. It is not associated with any other systemic anomalies, and what is important, unlike ROP, it is almost always unilateral, except those cases related to genetic mutations which have bilateral asymmetric disease. PFV can occur as anterior PFV, posterior PFV, or combined PFV. In anterior PFV, there is an opaque white membrane on the posterior surface of the crystalline lens, resulting in leukocodia as seen here in this color photograph. The opaque membrane leads to loss of vision and deprivation amblyopia, and this membrane may dehisce from the posterior surface of the lens, resulting in cataract and swelling of the lens, which may lead to secondary angle closure glaucoma. Ciliary processes are characteristically pulled inwards in PFV, and so are easily visible around the small lens as seen here in this clinical photograph. Microphthalmia, a shallow anterior chamber, and glaucoma from incomplete development of angle may also be present in these eyes. In posterior PFV, there is a stalk of fibrovascular tissue extending anteriorly from the optic disc, and this fibrovascular tissue fans out anteriorly. Pedipapillary retina may be pulled along the stalk, as shown here in this diagram, resulting in retinal folds and fractional retinal detachment, and this precludes surgical transection of the stalk during surgical correction of PFV. Anterior segment appears normal in posterior PFV, but the eye may be microphthalmic. In combined PFV, there is both an opaque membrane on the posterior surface of the crystalline lens and a fibrovascular stalk extending from the optic disc to this opaque membrane. And eyes with combined PFV can develop intralenticular hemorrhage from residual blood vessels within this stalk. Surgical correction for posterior PFV is transection of the stalk, but the stalk can be transected only if it contains hyaloid artery and does not have an attached retina. Surgical correction of anterior PFV involves removal of the lens along with removal of the opaque membrane behind the lens. Incontinentia pigmenti was previously known as Bloch-Schulzberger disease and occurs due to an X-linked dominant genetic mutation, and so male fetus with this mutation die in utero, and almost all patients are female. And due to the normal phenomena of random X chromosome inactivation, only 1/3 of IP patients develop retinal disease, and there can be difference in severity of retinal disease between the two eyes of a single patient and among family members. Skin lesions are characteristic of incontinentia pigmenti and appear as blisters soon after birth, and then typically develop hyperpigmentation along the lines of Blaschko, as seen here in this clinical photograph. The lines of Blaschko are the purported lines along which the epidermis migrates in a growing child. Other ectodermal tissues, such as tooth, as seen here in this clinical photograph, can also be involved in incontinentia pigmenti. Ocular features of incontinentia pigmenti include peripheral as well as posterior retinal ischemia, resulting in neovascularization, vitreous hemorrhage, and fractional retinal detachment, and cataract, optic atrophy, and foveal hypoplasia, as well as strabismus, can also occur in patients with incontinentia pigmenti. Patients with incontinentia pigmenti requires prompt examination of the fundus under anesthesia, fluorescent angiography, and laser photocoagulation to areas of retinal ischemia, and require long-term monitoring for at least 1 to 2 years to detect and treat areas of progressive ischemia. Familial exudative vitreoretinopathy, or FEVR, is a heterogeneous disorder with varied manifestations due to failure of the temporal retina to vascularize during development, like as in ROP, but in FEVR, this incomplete vascular development occurs in full-term infants. So like ROP, FEVR presents with peripheral retinal avascularity with a demarcation line, neovascularization, fractional retinal detachment, retinal folds running from posterior pole to the periphery, and macular dragging usually temporally, resulting in pseudoexotropia. FEVR is a bilateral entity but can be highly asymmetric. 50% of FEVR occurs due to a genetic mutation in the WNT pathway, which plays a pivotal role in retinal angiogenesis, and Norris disease, which occurs due to mutation in the NDP gene and is X-linked recessive, is considered to be a severe early onset form of FEVR associated with mental retardation and hearing loss. And FEVR due to LRP5 mutation is associated with osteoporosis, and so is important to detect. Unlike Coats disease and PFV, FEVR is bilateral, and unlike PFV, FEVR does not have stalk, microphthalmia, or centrally pooled ciliary processes. Unlike ROP, patients with FEVR does not have a history of prematurity, low birth weight, supplemental oxygen therapy, or other complex issues during neonatal period. And unlike ROP, patients with FEVR may have a positive family history, with parents and siblings often showing peripheral retinal avascularity and straightening of temporal retinal blood vessels. And unlike patients with IP, patients with FEVR does not show skin lesions. A number of genetic disorders may present with features of FEVR, and these include Coats plus disease, which we will discuss in the next session. Patients with FEVR require examination under anesthesia with fluorescent angiography along with laser photocoagulation to the peripheral avascular retina if there is no retinal detachment, or surgery with removal of the lens if there is fractional retinal detachment. Examination of family members of a patient with FEVR is important, as a high proportion may have subtle to obvious changes of FEVR, which is very important for diagnosing FEVR, and the name of FEVR includes familial. And genetic testing for LR5 mutation, because FEVR patients with LR5 mutation develop osteoporosis. To summarize, retinopathy of prematurity is a proliferative retinopathy occurring in premature infants. Established risk factors of ROP include prematurity, low birth weight, supplemental oxygen therapy, and a complicated neonatal course. ROP occurs due to hyperoxia from supplemental oxygen therapy of premature infants, which destroys the immature blood vessels lying at the junction of the vascular and peripheral avascular retina. This leads to hypoxia in the peripheral avascular retina, which secretes VEGF, inducing neovascularization. The disease occurs in two phases, the first phase being acute ROP, which is present during the first several weeks following birth, and the second phase is regressed ROP, which may persist lifetime. ICROP classification enables description of the disease in an individual infant during the acute stage of ROP. Parameters described in ICROP include zone of the disease, clock hour extent of the disease, and stage of the disease. Zone 1 refers to the posterior pole delimited anteriorly by a circle centered on the optic disc and having a radius of twice the distance of the foveal center from the center of the optic disc. Zone 2 is an annulus also centered on the optic disc and extending anteriorly from zone 1 up to the nasal ora serrata. Zone 3 is the remaining temporal crescent anterior to zone 2. Stage 1 refers to demarcation line, stage 2 to ridge, stage 3 to extraretinal neovascularization from the ridge, stage 4A to partial retinal detachment with fovea attached, stage 4B to partial retinal detachment with fovea detached, and stage 5 refers to total retinal detachment. The more posterior zone of the disease, the more extensive the disease, and the higher the stage, the more severe the disease. ICROP also defined plus disease, characterized by dilatation of veins and tortuosity of arteries in the posterior pole, and usually associated with media haze and pupillary rigidity, and aggressive ROP, characterized by flat neovascularization and ill-defined ridge or demarcation line, along with severe plus disease, and both plus disease and aggressive ROP indicate severe to very severe ROP. CRYO-ROP study defined threshold ROP as the presence of stage 3 ROP in zone 1 or zone 2 in 5 contiguous or 8 non-contiguous clock hours along with plus disease. ETROP study defined high-risk pre-threshold ROP with two subtypes, type 1 and type 2. Type 1 pre-threshold ROP refers to either of zone 1 any stage ROP with plus disease, zone 1 stage 3 ROP in the absence of plus disease, or zone 2 stage 2 or 3 ROP with plus disease. Differential diagnosis of ROP include entities which may present with peripheral proliferative retinopathy in an infant or a young child, such as familial exudative vitreoretinopathy, Incontinentia pigmenti, and ocular toxocariasis, and also entities which may present with leukocoria or white reflex from the eye, such as persistent fetal vitreous, Coats disease, and retinoblastoma. But none of these entities are associated with prematurity and typically occur in individuals with a history of full-term birth. Screening for ROP is required for all premature infants being born at 30 weeks or less post-conceptional age and or with a birth weight of less than 1500 grams. Screening is also recommended for premature infants being born between 30 and 32 weeks post-conceptional age and having a birth weight between 1500 grams and 2000 grams if they have a complicated neonatal course. The recommended time of first screening examination is 31 weeks post-conceptional age or 4 weeks after birth, whichever is later. Treatment options for ROP eyes without retinal detachment are ablation of the peripheral avascular retina, either with laser photocoagulation, which is currently the most commonly used modality for treating ROP, or cryotherapy, and anti-VEGF injections, which being non-ablative allow further growth of normal retinal blood vessels into the peripheral avascular retina. Surgery is required in ROP eyes with retinal detachment. CRYO-ROP study recommended treatment for ROP when they have or develop threshold disease, but as a significant proportion of eyes treated after reaching threshold had an unfavorable outcome in the CRYO-ROP study, ETROP recommended treating ROP eyes when they have or develop type 1 pre-threshold ROP, and this is also the current indication for treating ROP. Follow-up of ROP patients should be according to recommended schedules, which are different for untreated eyes, for treated eyes, and different for eyes undergoing ablative therapy and eyes undergoing anti-VEGF injections, and for regressed ROP. Recommendation of termination of follow-up include progression of normal retinal vascularization to zone 3 and attainment of 45 weeks post-conceptional age with ROP less severe than type 1 pre-threshold ROP, but follow-up needs to be extended to 65 weeks for eyes treated with anti-VEGF injections because of higher chances of recurrence of acute ROP following treatment with anti-VEGF injections. Regression of ROP, either spontaneous or following treatment, is characterized by reduction of plus disease and media haze, better pupillary mobility, decrease in stage of severity, and in untreated eyes, progression of normal retinal vascularization. ICROP also defined reactivation of ROP, which is a recurrence of acute ROP following initial regression. It occurs frequently after treatment with anti-VEGF injections, less commonly after spontaneous regression, and almost never following laser photocoagulation or cryotherapy. Regressed ROP is the phase following involution of acute ROP. Posterior segment signs of regressed ROP include retinal detachment, retinal folds, macular heterotopia, and straightening of temporal retinal blood vessels. Anterior segment signs of regressed ROP include corneal irregularity, band keratopathy, cataract, and glaucoma, typically angle closure glaucoma. Other features of regressed ROP include myopia, anisometropia, strabismus, and amblyopia. ROP patients require long-term follow-up to monitor and treat complications of regressed ROP. It has been a long session, and thank you for listening.